limbs that you're tying through one cannula, isolate them there, and push the cannula right up to the tissue so that you're not entangling any soft tissues, anything else between your knots. Now as a matter of principle, at least for most of my fellows, they always use a cannula when they're tying a knot, because you get through all the things about any soft tissue entrapments, etc.
Sure.
And if you're not using a cannula, then go right down to the bottom of the tissue and pull both the limbs in one go with the suture manipulator so that you
And
don't
sometimes
entangle any
they also
soft
get
tissue.
attached
Yeah.
to the curve. This is very common.
I think
That's
this
what-
is a very, very important
Invisible.
because sometimes, and this is for the younger guys, those who go and watch some surgeries by, fantastic surgeon who can do occasionally a knot tying without the cannula.
Sure.
But you can be in a mess. So it is, as he very rightly said, it's very important that you must see the limb. You can do rest of the work without the cannula.
Sure,
But once you
when
start
tying
tying the
knots.
knot, place a cannula, pull out one by one each limb so that you don't twist. If you pull them together, sometimes you will twist.
So it's very important because many times your fat and your tissues, even your thing gets entangled, and then you're struggling because once it's in, then
especially in
cuff repairs, yes.
much more than instability. And another thing is that Burkhardt says this. You don't need no more than 2 cannulas, and generally with 1 or 2 you can fix all the problems. But what you can do is that it's very nice to use very small portals without cannulas and careful repairs as waiting portals, because it's very important to separate these sutures, not to make a mess with them. So I always take a lot of care to separate, because if not, you can make a mess, and then to resolve the mess, it's very hard.
I don't think so. It hurts ego if you put a cannula, because there's no reason to be foolhardy, as you said, absolutely.
And try and work out the sutures from inside the joint. You can have a mess outside, but as long as you pick them from the inside,
Sure.
you're
Yeah.
fine.
Sure.
When you've got multiple sutures, you should select your sutures, and as you said, using the same time, you get both the limbs out once to make sure that you got the correct limb and they are through the same cannula.
That's the most important thing, to make sure that you don't have any interpositions. I'm not using cannulas,
I know that.
and I don't use cannulas for a reason that I have more maneuverability without the cannulas to work in the joint. But if you take the 2 limbs from the cuff, not somewhere in the bursa, from the cuff, both of them, make sure that they are free, and you put them together, then you have no problem.
That's what is called as virtual cannula.
But it's virtual cannula.
That's a virtual cannula. You got this, and you pull it out. That's what a virtual
If you have
cannula.
any doubt, and I agree with Kapil, if you have any doubt, especially if you are starting your arthroscopic operations, use one cannula to do the knot
You're not
tying.
tying, yeah.
Yes.
You will not regret, for sure.
Absolutely.
Thank you, Dr. Pradeep, for an excellent talk, and we had a good discussion. Now,
Thank
the
you.
last lecture of this session would be by Dr. Raju Ishwaran. May I call Dr. Raju? And his topic is arthroscopic shoulder portals, anatomic and clinical considerations. And he would further specify on standard portals and type of surgery specific portals.
Good morning. I'd like to thank the organizers, especially Dr. Amit, for inviting me here. I'll be speaking on portal placement, standard portal placement in shoulder arthroscopy. And the front door to the shoulder is perhaps through the back, and posterior portal is the first portal that you would want to make whenever you're starting your shoulder arthroscopy. It's the workhorse portal, and in the textbook you may read lot of recommendation, 2 centimeter below this, 1 centimeter medial to that, but generally the soft spot of the shoulder, which can be easily located by palpation after you have marked out your bony contours, is a good place to start out from. And this is an intraoperative photograph. This thumb can easily palpate the joint line at the posterior side of the shoulder, and once you are able to rock the humeral head back and forth, one can give a skin incision there and start making the posterior portal. Initially, during my shoulder arthroscopies, I used to struggle quite a bit in making posterior portals, and this particular tip described by Anthony Romeo really helped me. This is called the Romeo 3-finger shuck. Essentially what it means that the shoulder which is being operated upon, say if it's the right shoulder, the right hand, or if the left shoulder, the left hand. So in this particular instance, the right shoulder, and you use the right hand of the surgeon with the index finger resting in the region of the Neviazer portal. You place your middle finger over the coracoid, and then your thumb would be roughly equidistant between the index finger and the middle finger. So roughly this distance is equal to this distance, and with this thumb you can actually shuck the humeral head back and forth, and you can actually get a feeling of the joint line posteriorly, especially if you have a thin patient. So this is a useful maneuver to consistently locate the posterior portal. Unlike the knee joint, this is a deep portal. This has to traverse through the thickness of the deltoid and the interval between the infraspinatus and the teres minor. So sometimes locating a posterior portal can be the most difficult step when you are starting out with your shoulder arthroscopy. But once you have made the posterior portal in the correct location, most of your arthroscopy, you can look at the anterior labrum, you can look at the biceps, the subscapularis, and in a capacious shoulder, the inferior recess. You can go around the humeral head, see the insertions of the rotator cuff. You can even have a glimpse of the posterior labrum if you retract the scope well enough to see how the posterior labrum is attached, especially in the superior portions, through the standard posterior portal. Once you have made the posterior portal, to locate the other portals for your surgery depends on what exactly it is that you want to do. Now, speaking of glenohumeral work like an instability surgery, 2 additional portals are usually required. So one of them is the anterior superior portal, and the skin marking for this portal is generally adjacent to the anterolateral angle of the acromion. This is of course the surface marking of the coracoid process. And these portals are placed in an interval of, in a region of the shoulder which is known as the rotator interval, and this rotator interval is bounded by the subscapularis and the biceps tendon, and this is a fairly large interval, at least on the inside, where 2 portals can be safely placed. And sometimes in instability surgery it is useful to view from the anterior superior portal. Oh, I'm sorry, just so here the view is totally different compared to what you see from the posterior portal. This is what is known as the bird's eye view of the glenoid, and you can easily see all the way down to the inferior angle of the glenoid, and this is especially useful for instability work when you want to see whether the glenoid labrum is scarred at the level of the glenoid or whether it has gone medial to the glenoid. So I always like to use the anterior superior portal whenever I am doing my instability work. Another portal that needs to be established for a routine instability work, a Bankart repair, is the anterior mid-glenoid portal, and generally the anterior mid-glenoid portal is located quite adjacent to the coracoid process. This is the usual location of the anterior mid-glenoid portal. For an instability work, you might want it slightly higher than what is depicted here, so that you get a good angle to drill all the anchors that you want to drill onto the surface of the glenoid. And since 2 portals are used in a very tight interval of the shoulder, one should ensure that at least a centimeter of skin bridge exists between the 2. This of course has useful implications in healing of the skin, as well as avoiding collision of instruments between these 2 portals as you are doing the surgery. Now coming to subacromial work, again the same posterior portal that you used in the glenohumeral work can be used to view the subacromial space, that is the initial viewing portal, but for any kind of instrument work in the subacromial space you would need to establish a lateral portal. Again the skin landmarks come in handy. One orientation line which is again drawn at the level of the soft spot is a very important line to draw for marking out your lateral portal, because the portion of the acromion anterior to this line is what is clinically important in most cases of subacromial pathology. Also 5 centimeters below this particular border of the acromion traverses the axillary nerve, so you would want your portal to lie above this particular line. So depending on where your portal is and depending on the tear pattern, you could either have an anterolateral portal or a posterolateral portal. Essentially, there are no fixed landmarks in terms of centimeters or millimeters from the acromion that you want. The spinal needle is your best friend. So using the spinal needle, whatever best access you can get to the target pathology, that is the kind of portal that you should use. This is one illustrative example where a rotator cuff repair is being done. The scuff is being viewed from the posterior portal or the posterolateral portal, and this anchor is coming in from the lateral portal. So this is the kind of view that you get from the posterior and the lateral portals for the subacromial work. And sometimes as pathology dictates, we might need to use some infrequently used portals. So if a slap repair has to be done, a supralateral accessory portal or a portal of Wilmington needs to be established. Neviazer portal is a pretty interesting portal. This is very useful when you want to do a rotator cuff repair, especially if you want to take your suture bites with the help of instruments like the ideal suture passer or an AcuPass or something like that. But one thing has to be kept in mind, as Dr. Levy was mentioning, that suprascapular nerve is pretty close to the Neviazer portal. So that is something which must be taken care of while creating this particular portal. Similarly, on the anterior side, one may infrequently need to make this 5 o'clock portal. 5 o'clock portal violates the subscapularis, and therefore it must only be a percutaneous stab, and then using percutaneous instruments one can just pass an anchor through the 5 o'clock portal, with all the other work being done from the standard anterior portals. Because if you put a 8 millimeter cannula in the 5 o'clock portal, then I think a lot of violation of the subscapularis is being done. So that's a gross overview of the shoulder portals. One must of course keep in mind the rich neurovascular anatomy around the shoulder. Particularly anything medial to the coracoid is not a very good idea. And it is also useful to remember that the posterior portal, which is generally here, is not very far away from the quadrangular space and the triangular spaces, which are rich of vascular structures. So one must keep that in mind. I thank you very much for your kind attention.
Thank you, Raju, for a very excellent and a very dynamic talk. I forgot one more thing to illustrate about Raju. Raju is a fantastic computer wizard. He is developing a lot of applications for Indian Arthroscopy Society. So thank you, Raju, for the help. Any comments? Dr. Kapil, you can talk about your 5 o'clock portal.
Yes, that's what I was going to say. Yeah, just a comment on the 5 o'clock portal. I don't use it routinely for my instability work, but occasionally if I'm using a knotted anchor, I find it very easy to use a straightish instrument like an ideal suture grasper or an AcuPass to come percutaneously to the 5 o'clock portal and grab the suture from there. So you're invariably struggling to get down to the 6 o'clock position from the top. So if you're having a bit of a struggle, I find it easier, especially because I do everything in the beach chair position. It's very easy to go right down with that straight portal, and it's just a few millimeters thick. And all I do is to pierce the labrum with it, grab the suture and come out, and then I can retrieve them from the standard portals and work from there. So I think that's a useful portal to have in times of difficulty.
Just a comment. Well, I do a lot of stability as everyone here, but I have tried once the 5 o'clock portal, and I only do arthroscopies in beach-chair position, and I had a lot of difficulty in finding the good position and in opening the subscap. So now what do? I do a very low portal in the basically in the line of the superior border of the subscap, and my second one is just on the other side of the biceps, always establish it with a spinal needle. I'm going to show this in a video in the afternoon, and a little bit higher. So then I am always having two different approaches to the
Inferior.
the anterior surface of the glenoid, and especially when I am using anchors with only one suture, then it's absolutely possible to make this surgery only with one portal. So with monoloaded sutures, with monoloaded anchors, you can put 3, 5, I mean 3, even 4 anchors only with a single portal. Okay, but when you are using double loaded, doing 2 portals, I guess, is absolutely fundamental.
True. And one more trick that I use to reach the inferior part of the labrum in instability is what I learned from my colleague Dr. Ashish Bhabulkar. I take the first bite from the posterior portal using a suture lasso of the opposite side, right shoulder, left suture lasso. So the posterior portal allows a very low entry, and especially I have started using double loaded anchors for the inferior position. So that is something which is really handy.
So when you take that bite, are you conscious of where you put your posterior portal? Because at times you can't just go over the glenoid and take the...
In most of the instances, the posterior portal is generally subequatorial, so generally it's not an issue. If I've been, sometimes you are unlucky in surgery, so in that case I use some other strategy to take that bite.
I think this is a very important thing, Amit, what you just said. The classical 2 centimeter inferior and 1 centimeter medial is actually too much classical. We always have to, that's where this thing comes. what we need to do is ensure that it is placed almost at the level of glenoid or maybe a little millimeter lateral. Because if you're too medial, then none of the instruments would go parallel.
Would
and
go
everything
parallel.
will go up. And then if you want to take the inferior most bite through posterior, it's over.
Yeah.
And none of the instruments would also reach.
Especially for a lateral position.
Yes, sure.
Another option to use is accessory posterior portal, which is lateral and inferior to the
Yeah.
posterior portal, and then you can use that to pass the suture through the.
Some guys call it the 11 o'clock portal.
Yeah.
The 7 o'clock
and
portal.
actually we-
7 o'clock, I'm sorry.
We've just published recently use of a half pipe cannula, the one they use for knees and hips and all that, just to use it as a portal, so you don't need any cannula, just slides the instruments back and forth to grab the inferior part.
Sure, and just a comment maybe for the audience. When I am doing my posterior portals for all scopes, I always put first a 14 needle, 14 spinal, number 14 spinal needle, and then I feel with my hands if I am passing the capsule, if I am touching the glenohumeral space, and then I inject something about 20 or 15 cc of saline, and once it's coming back, so I am sure I am in the right position, and this is something that always makes me sure that I am doing it in the right position, because 4 or 5 millimeters of difference in portals make a lot of difference. So we must be very obsessive, I would say, with portal placement.
True.
Thank you, Raju. Thank you, everyone, for the excellent discussion of this session. Thank you. And now
I
coming
guess
to the
it's,
break for the
yeah, I guess it's becoming a bit toxic, so we can probably break for coffee and assemble here in say about 15 minutes, 1:45. Getting quite a few out there on a regular basis, and so you could probably, kind of ask him questions if you are interested, so as how you get there and what is the training sort of schedule like. Over to Kapil.
No, just do one presentation. Thanks, Amit. I'll just take probably a few minutes to talk about, because I get a lot of formal and informal queries about how people can come and train in the UK, and probably Offer will tell his opportunities tomorrow. And I've got a little bit of a better perspective on training opportunities, because I am the training program director for my deanery, so I can tell you what's happening in the training in the UK as well at the moment. One thing is for sure, that it's become increasingly difficult for non-EU candidates to come to Britain for training, on a formal training. I think we were lucky that when we went there, there were visa regulations and immigration rules were not that strict, so that we could get there. So at the moment, your best opportunity to come for a training post in which you are allowed hands-on operating is through what we call the Medical Training Initiative Scheme, which is run through the Royal College of Surgeons in Edinburgh. What you need for that is a sponsor in the UK. So, for example, if you're coming to work with me, I am your local sponsor, and we need 2 referees here who are able to give you and vouch for your abilities, etc. I usually do an interview process, essentially just to find what your aspirations and what your goals are, and to see what level of training that you want. Once you go through that, for this, let's be very clear, you don't need any exams, you don't need to sit the PLAB, you don't need the MRCS. The only thing that you need is IELTS with scores of, I think, 7.5. Is it 7? No, it's 7.5. Yeah. No, it's 7. It's 7.5 across all the segments of the IELTS. So there is an application process which you fill up, and I send your sponsorship forms to the Royal College. There is a fee for processing this, which is, I think, about £600 or something like that, which you have to pay to the college for the processing, and then you have to pay money to the GMC for registration. This is a scheme which you can come to the UK on for a maximum of 2 years. You are paid a salary, and if you come to our institution, you do some trauma on-call commitments as well, which increase your salary. people ask me about the salaries. I think in the first year of your job, your take-home salary is about 2,000 or 2,200 pounds roughly. And this is after your taxes and national insurance has all been deducted. You have to pay for your own accommodation though. And so if you're interested, the other opportunities to come on short-term observerships, which you pay your own passage, and you can spend time for as long as you want. I think people get bored in about 6 weeks' time and they want to come back because they're staying in this hospital accommodation and with no family support or whatever. Not much to do after 5 o'clock except if you want to go out and drink every night. But good booze, yes, good beer and good whiskey available. So that's it basically. So if you want to have a think or chat about it, you can find my email. Amit has got my email. Or if you go to the website of ISKSA, ISKSAA, there are further details available on the fellowship on that as well. Okay. Right.
Thanks a lot, Kapil. And now I would invite Kapil and Raju Ishwaran to chair the next session on rehabilitation. We'll probably start with Deepthi Adla and keep Ashish Babulkar the last. I don't think Dr. Nag is here.
Thanks, Amit. I would think that this is probably the most important session because whatever we do, if we don't rehab our patients, either pre or post-op, the results are going to be poor. And there's no point in blaming the physiotherapist or the rehabilitation person for our poor results. And in a lot of ways, you have to, I think, direct your physiotherapist or rehab person what you want to do. Some of the physiotherapists in the UK are excellent, and they're probably, they lead the rehab process. But here, I think it's different. So, over to you, sir.
Yeah, I'm just going to talk about rehab in unidirectional. I'll leave the multi-direction more difficult one to the next speaker. Essentially, we know that traumatic ones recur quite often, more so in the younger than in the older people. Now, one of the reasons why this happens is because of the type of collagen you have in the capsule of the shoulder, which changes with age. When you are younger, you have more type 3. As you get older, you get more type 1. So it's less pliable, hence it comes out less often. Now, shoulder stabilizers, do you know that they are static and dynamic? The static ones are the labrocapsular complex, the bony and the negative pressure in the shoulder itself. But in a trauma situation, you see there is a loss of this integrity. So the negative pressure goes down, the complex is gone, the bony congruency sometimes is gone when you have a bony Bankart, and the negative pressure is gone. So the static ones are gone. The only one you have to rely on is the dynamic ones, which are the scapular muscles, which will hold the scapula in the right position. Then your rotator cuff, which will provide the concavity compression to hold the head into the socket itself. And the long head of the biceps also has a good significant role. So it's very important to recruit your scapular muscles and your rotator cuff. The principles: first you identify the pathology, then you control the pain and inflammation, then you restore the shoulder movement, then you go on to protecting the static stabilizers, protecting them, not holding them or repairing them, and also to obtain good function of your dynamic stabilizers so that it holds it into the joint, and then improve your proprioception and to correct the kinematic chain. The goal is to provide an unrestricted return to pre-injury activity. Unrestricted is very, very important. Many a times patients have dislocation, they just avoid doing certain things and manage throughout life. But that, if you get an unrestricted, that means your outcome is good. Now, the key factors to consider are the onset of duration, the frequency, as we have alluded in the history, and the degree of instability, as again was alluded in the history. Direction of instability, very important to know which muscles to recruit and which not to. Associated lesions, again, bony Bankarts have a different protocol to non-bony Bankarts. And pre-dislocation activity level is very, very important, as was in the discussion previously. that a rugby player has a different way of managing than a non-rugby player or a sedentary worker. And it's very important to individualize the rehab program. Whatever we say, you have to individualize to the patient you have in front of you. So history, examination and imaging, very important as we had covered so far in our lectures. We go in phases. First you wait for the tissue to heal, and then you get the movement, and then you strengthen it. So phase 1, you diminish pain by putting some ice on it, analgesics, protect the healing of soft tissues with immobilization in a sling. Then again there is a controversy about, well, a debate about immobilizing in internal rotation and external rotation. So, but for posterior dislocation, obviously you abduct and external rotate. For anterior dislocation, you can either use these type of slings or these. These are in a way, I think, more helpful because it avoids external rotation, also supports the arm closer to your chest and maintains the neutral abduction. Now, looking at the evidence, main reason why this came about was research by this man who looked at MRI, cadaveric and clinical studies to see what the labrum looks like in different positions of rotation, and he found that in external rotation the coaptation of the lesion onto the labrum is good. That's the reason why he suggested this. Now, initial paper he said that the recurrence rate was 0 in external rotation, but the later paper in 2007 he said the recurrence rate was about 26%. But interesting thing in this was that the compliance was better with external rotation. Maybe the Japanese people are more disciplined than we are. Okay. Now, another study from Norway, again they look more disciplined as well than us, but I don't think this was translated in a study done in UK in Oswestry, where they looked at the compliance was low, and in fact they had to stop the study before because the compliance was very low for the external rotation group. So I prefer to go for the internal rotation because it's of better compliance and it's more convenient for the patient. The duration of immobilization, again there are some papers which had looked at various aspects of this, and they found that if you immobilize a patient in after shoulder dislocation, you get decreased joint proprioception, reduced muscle use, so atrophy, and loss of motion or stiffness. That's the reason why you mobilize them early. But if you mobilize them early, you could dislocate. But there are papers which have shown that early mobilization versus no 3 to 4 week mobilization, no difference. But there are papers after that which have said 3 weeks is probably ideal rather than going for 2 weeks. So you could go for 3 weeks, but you can individualize this again according to a patient, depending on the patient's understanding of the problem, patient's occupation and the severity of the dislocation. Phase 2. Once all the pain is reduced and he has good static stability and adequate neuromuscular control, you go for regaining motion and start strengthening your muscles within the safe zone. You do isometric cuff strengthening, both internal and external rotators, and you can do closed chain exercises so that again you are in the protected zone, you are not dislocating them. And in phase 3, you go for advanced strengthening. When you have reasonably good power in the muscle and you have regained full range of movement, then you go for the next level. So the main idea is to enhance the endurance of the muscle. So you go for more reps, low strength, and improve the coordination. So you go for cuff strengthening and scapular strengthening. The prone rowing is supposed to be very good for dislocations. Then you do graduated external rotation. So you go from this with resisted external rotation, then you go to 30, 60, then you go to the full 90. And these sort of exercise also very, very useful for rehabbing the unidirectional instability. Now, if a patient is a sportsman, we need to target getting them back to the pre-injury level. So you need to get them to go for more complicated physiotherapy to improve the proprioception and to strengthen those muscles around. And you also give them various tasks like these wobble boards, and when they start standing on the wobble board, sometimes you give them a ball to put them into the trampoline and catch them back, just to get the coordination back, depending on what sport they're going back to. Traditionally, post-surgery, we tend to follow these sort of protocols, where first day we immobilize it, 3 weeks later you start weaning off the sling, start pendular exercise in clinic, no forced movements, and avoid external rotation beyond 20. And at 6 weeks you start full range of movement and strengthening of scapular and cuff muscles, and after 10 weeks you start the vigorous strengthening. That's the time when the tissues would have been more solid in their healing. But we've moved on to accelerated rehab, because the reason is that if you look at the MRI studies and the cadaveric studies, you've noticed that the coaptation zone is more wider than you think when the arm is adducted. That's the reason why you can still go up to 20 degrees of external rotation without putting strain on the repair or the anterior labrum. That's the reason they went on to accelerated rehabs. So there's less tension on the repair. That's the most important thing. In the accelerated rehab, we start at day 1, you start pendular exercises, day 3 isometrics, day 7 forward elevation to 90, and 2 to 4 weeks you go to forward elevation of 90, external rotation to side of 20 degrees, and at week 3 you go to abduction of 30 and then start external rotation. Week 5, external rotation at 90 degrees of abduction to tolerance, and then you go for the dynamic phase of strengthening. Results: looking at the recurrence rate, you have the conventional here and the accelerated here. In fact, the accelerated had lower recurrence rate, but statistically not so significant. Maybe that the mechanical, the input you get from the movement you're doing improves the healing, like in fracture healing. That's probably why it does better than conventional. And the instability scores were also same, so there was no difference. So with accelerated rehab, lesser post-op pain, earlier regaining of shoulder motion, and earlier return to function. But the long-term results are similar in both. So you can choose, if you feel that the patient is not compliant with your therapy, then you could probably go for a conventional rehab. But if you feel that they are compliant and they are sports people, want to get back to activity very quickly, go for the accelerated rehab. But you need a very good physiotherapist for it. Thank you.
Thanks very much for a very useful talk. Before we go any further, can I just take a straw poll of the faculty? And how long do people immobilize their primary young dislocators after their first dislocation? And what is your evidence for that? Sergio, you were volunteering?
Yeah, it's a good question. I put them no more than 10 days, one week, because depending especially of the age, I know that the chances of this patient evolving to having a recurrent dislocation is very big. So actually, I was seeing all the talk, and I was thinking that this talk would lead to another very important one that I'm just giving the title, that is when to operate an anterior instability, in first episode or after the second. Do I have some evidence in literature on this? Yes, and the evidence is that as long as I have seen, there's still no evidence. So in 2010, in World Shoulder Congress in Scotland, Dr. Peter Habermeyer, he presented a paper saying that it's still not clear if you should operate in first episode or in second episode. And I have seen a tendency in practice that in competitive athletes, especially when they have to come back to sports, they are being operated after the first episode. But the thing is that when I see, I agree with all of this, but when I see a first dislocation, especially in a guy that is under 30 years old, I'm putting a sling and I'm waiting to see what happens. And until proven contrary, much probably he will dislocate again. This is what happens with the great majority of the patients. So I don't believe too much that with physical therapy, a first dislocator will not dislocate again. It depends much more on the ability of that labrum, the anterior-inferior labrum, the Bankart lesion itself, to heal properly or not, much more than in physical therapy.
So 10 days in a normal sling and then rehab?
Max,
nice.
7.
Alfred?
Maybe because I've got more grey hair, I'm more conservative. I keep them for 6 weeks. The problem is that I do believe Itoy, because we all see that. But the problem is that these guys are coming to us late. If you miss the first few days, it got stuck in the wrong place. So I believe in external rotation bracing, and I did some elite players, and they were very, very compliant with that. And they never dislocated again. But again, there were some other studies that the people were not as compliant as the Japanese, and it didn't work. So I keep them 6 weeks. If I get them in the first few days, I keep them for 6 weeks in external rotation race. Otherwise, again, I tend to think that there's not much point. I give them the chance the first time, but I agree. If they're young, they will read this.
So we've got 10 days and 6 weeks.
Yeah.
Any takers in the middle from the
And it's funny that your patients, they can stay 6 weeks, because in Brazil, after 1 week, they are pain-free and they say, oh, I'm going to tell my doctor, but I'm going to throw this thing away.
Maybe they're coming back to see me after 6 weeks. They put it in the waiting room.
Yes. Okay.
I guess you don't push them too hard to keep it on, because then you know that he's going to come back to you.
Yeah, but but honestly speaking, it's not that I want to
No.
You know, is that I don't see a point, and there is literally in what I'm saying now. I don't see a point in making so much rehab after a first location, especially if the guy is under 30, 25. If in the end the chance of the existence of second episode is so high, regardless of all the good intentions of physical therapy.
Now, I guess if you go for the physical therapy, irrespective, the muscles you have developed will always be useful for your surgery as well. So you're not losing out anything.
Okay.
Any other questions or comments?
Thanks
very much.
Can I now invite the next speaker, Professor Levy, to speak on rehabilitation for multidirectional instability?
This computer fired up. We are running a prospective randomized controlled trial on the early versus late rehab as well. And for our early rehab, we don't give the patient any instructions after arthroscopic stabilization. They can use their arm within comforts of pain. They can take it off for dressing, undressing, showering, and everything else. And we've got data on 12-month outcomes, and there is no increased recurrence as yet. So I think if you've achieved a good, solid repair intraoperatively, you can probably press ahead with accelerated rehab.
The worry is the situation here is that there are lots of variables, like the physiotherapy quality you get, the compliance of the patient, the understanding of the patient is very, very critical here.
Oh, don't worry about it. The compliance over there is not good either. The highest defaulters are the young dislocators who don't attend their post-op or their clinic visits. The moment their shoulder is fine, they're off. So the compliance is poor. Often.
Okay, thank you very much. Thank you, Amit, for inviting me. I'll talk about more about the evaluation and a little bit touch on the rehabilitation, because most of the rehabilitation is similar. It's just a patient selection, as we talked outside. And instability, we have to define what we're talking about. This young girl, she's very lax, but she's only unstable on one shoulder, the one with the arrow on. And she could always do that. So laxity is not instability, and instability is not laxity. And I think the best classification system is the Stanmore classification system by Ian Bailey, which have this triangle, the Stanmore triangle, that we have on. Just a sec. That we have on one side the structural traumatic, which is the rugby players, the structural non-traumatic one on type 2, and the type 3, which are the non-structural muscle patterning or habitual or voluntary. And we can go back to the classification of Madsen, of the Tubbs and Umbry, but again, this is too simplified, and it doesn't really get the details of the different subtleties between the different
classification. So the Bailey triangle gives us, as I said, the three polar groups: the traumatic instability, the non-traumatic, they have a structural instability, and the muscle patterning that anatomically they are fine. They may be a bit lax, but they are fine. There's nothing anatomical there. Again, the traumatic one, straightforward, as we talked before. There's a clear episode of trauma, damage done at the injury, the capsular tear, the Bankart lesion, and again, the recurrence depends on the first age of dislocation. If they are younger than 25, they have almost 90% or more than 90% of recurrence. And usually, I think eventually, as Sergio said, they will come back to us, we'll have to operate on them. Now, when we have a patient with instability, the diagnosis is important, the age, whether it was an injury or non-injury, what was the mechanism and the severity of the injury, the direction of the instability, the degree, if it's clear dislocation, if it's just subluxation or just pain on certain positions, and if a reduction was required, whether it sedation, general anesthesia, whether it popped in spontaneously. All this will tell us a little bit more about this patient. Recurrences, if there's any signs of laxity or signs of instability that we heard very nicely before. Again, hyperlaxity. This young lady belongs to the group which is the group 2. And again, there are signs of laxity like the sulcus sign, the draw sign, anterior, posterior, the Gauget, Professor Gauget hyperabduction sign, which again, there is the Gauget sign and the Gauget test. The Gauget test gives you an apprehension inferiorly, and you know that this patient might be inferiorly unstable as well. Again, we heard about all the apprehension tests before, and all that we have to assess that the patient before we make our decisions. Again, there are these patients with a chronic microtrauma. Again, they are on the group 2. They have a structural, they may have a labral injury, they may sublux, partial cuff tears, and due to overuse, muscular overuse, or poor mechanics, playing tennis for instance, or bowling, or anything else. But we have to be aware of these patients. And these are the patients I thought is important to diagnose. These are the muscle patterning one. First of all, you can look at his face. He's completely indifferent. His shoulder pops in and out, and he's completely indifferent to that. He came here because maybe his mother told him that he needs to go and see the surgeon for that, or he may have some secondary gain by doing that, but he's completely indifferent. His face talks about it. And it may present as posterior positional dislocation, as this guy is showing. Beware of these guys. We have to really diagnose them, because in these guys, no surgery. Sometimes they come to us, they have a big scar in the front, a big scar in the back. Maybe a few times these scars were open back and forth, and all the operations were necessary but the first one. Okay. Again, this young lady, she comes and she can show us, and she's smiling, she's happy, She can show us what she can do. She can dislocate her shoulder. And sometimes these patients may present with unreducible dislocation. They come to A&E, we get a phone call, this patient came again with another dislocation, we can't reduce the shoulder. Or we reduced the shoulder, send the patient for an x-ray, she came back and she was with the shoulder out again. I mean, again, these guys, these patients have something else. They may not need us as surgeons, they may need some other help. So we have to be careful. There's a few tests that we have developed to assess these patients. You can see when he lifts his arm up, he's got positional posterior dislocation on the shoulder. Clicks out, clicks back in. Now, I'll tell this young chap to forcefully externalitate his arm and do that. By doing that, he can't contract the pec major, because I tell him to hold it like that, and then he doesn't dislocate. Okay? That's a sign that this is muscle patterning. He's overcontracting his pec major and subluxing. You can see that he's laughing as well. He's having fun. The other test that we published recently is the hand squeeze test. Again, for the same technique, for the same instability. You can look at this guy again, posterior positional instability, yeah. And what we do, we ask I mean, this instability actually happens because of muscle imbalance between the weak external tators and a strong internal tators, usually the pec major. And this pushes the head backwards when you reach to the horizontal. And what we need to do is to work on their muscle pattern, to improve the muscle pattern, to strengthen the posterior rotators, and to make sure that the pec doesn't fire in the wrong timing. And so we actually doing this hand squeeze test, which is first we observe the positional posterior shoulder dislocation in elevation of the arm and the hand in pronation. Second, the patient is asked to squeeze the examiner's hand, the other hand, as hard as possible. By doing that, you distract him from the shoulder. And then when he does that, he lifts the shoulder up, it doesn't click out because he's distracted not to contract the muscle. Now, if there's no positional posterior dislocation, this is a positive. If he still has a posterior dislocation, this is negative, and then we have to look for some pathology or think that this is not muscle patterning. This is an example. This young chap, again, clicks, and then hand squeeze. I'm asking to squeeze hard. Squeeze, 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 and he doesn't dislocate the shoulder. Now, I'm actually attracting his attention to squeeze my hand, and he forgets to contract the muscle, the pec major, on this side. Okay. Again, you can see here he's dislocated he's dislocated here, but when he's doing it, squeezing my hand, he's not dislocating. So again, if it's positive, no further investigations. The program is intensive physiotherapy with biofeedback, strapping, and all the techniques to improve his proprioception and muscle control. Actually, very good physiotherapists within one session can actually work out and work with the patient to realize that he's doing it, it's not on purpose, it's subconsciously, but that he can control it better. And definitely no surgery, not to touch them. If it's negative, further investigations like arthro-MRI, and if there's a structural lesion, then obviously arthroscopic treatment. Because these patients may have some structural lesion as well, and sometimes you have to fix the lesion and then do the proprioceptive and the rehabilitation to get them out of it. But these are the minority. Okay, so when we looked at our 10 patients in this study, 8 of them were positive, 8 with 10 shoulders were positive, and the whole treated conservatively without a problem. 2 were negative, and in these 2, we had a labral lesion in arthro-MRI and had an arthroscopic stabilization and did well. Yeah. So they had some patterning, but they had a reason to start a patterning with a lesion. But these are the minority. Again, imaging, we talked about it before, arthro-MRI and CT scan if necessary. Again, the indication for surgery, non-traumatic instability, is recurrent dislocation, subluxation, pain, apprehension, inability to return to the same level of sports, or failure of the conservative management and rehabilitation. And again, make sure that before that, we got rid of the patterning. They are not patterning anymore. EUA, again, it's an important part of the investigation, and we're using the co-fill technique, with grade 1, 2, and 3, and in internaltation and externaltation and abduction to see if we manage by stretching the capsule to stabilize the shoulder. Always compare it to the other side, and then the arthroscopic assessment, again, to assess for all the lesions. And if you see a Bankart lesion, then you know that this got an anatomical or pathological lesion there that needs to be, or a Hegel lesion, as you can see here, needs to be repaired arthroscopically. Again, if we need to do a stabilization, I tend to use this purse string technique, which is a very simple technique. As you can see, because the glenoid is a pear shape, if we have a Bankart lesion and we put an anchor at 4 o'clock, and take one suture at 6 o'clock and one suture at 2 o'clock, and we tie it as a purse string. You just close it around the neck of the glenoid. And it's a very simple in concept. It's a very straightforward technique. You could see this video here that shows how it's done. You could get a nice bumper in the front of the glenoid. As you can see here, this is the state it was, the labrum, the Bankart lesion, and that's after using the purse string with only one anchor. And again, it's not the numbers of anchors that you're using. You don't need more than one anchor to get it posed nicely to the glenoid. If it heals, it heals, it will be fine. If it doesn't heal, even with 10 anchors, it will not heal. So the only thing that I would say that I'm more conservative with that after surgery and keep them 6 weeks in a sling, because I'm using only one anchor. Now, if you need to, you have to put another, you want to put another anchor there. If you still have some gap or something, you can always use that. So this is a very simple, excellent long-term results. And I think it's important to think about the cost, because this is one anchor. The cost is by far less than using 3 or 4 anchors, without compromising the results. Again, muscle patterning, it's a contraindication for surgery. One of the hints may be some dyskinesia of the scapula with the patients. When you see the patients, beware when you see that. And the rehabilitation, again, as we heard from Dr. Adler before, it's mainly proprioception, core stability, scapular stability, rotator cuff rehabilitation, biofeedback using either EMG, or you can have a biofeedback by the strapping as well. The physio know how to do the strapping to get the feedback back, or sometimes they stand near the patient and scratch his muscles to give them feedback back to know which muscle to contract when. Again, I use Botox a couple of times in very severe cases just to get them out of the loop and try to teach them how to use the muscle correctly. And one of the the main speakers on that is Ben Keebler about this scapular dyskinesia. One thing that went out of fashion, and we, I think, were the only one to have a reasonable results with that, is the thermal shrinkage for this multi-directional capsular instability, but patients that were not muscle patterning. And we use it different from the others. We used very low setting on thermal shrinkage, and we had good results in about 2/3 of the patients. We did a few patients that had to have repeated shrinkages, so they had 2 or 3 times shrinkage, and then it brought it up to about 80%. And again, maybe this radiofrequency is indicated to patients with lesser degree of instability, just to get them a better proprioception. We did a study with proprioception, and maybe what we did by that is just, there's a question: how did we improve the proprioception? By burning the cells in the capsule, or the Golgi apparatus, or whatever. And possibly because we burned this in the capsule, the proprioceptors of the muscles came into action earlier, and that's why they were better. I don't know. I don't have any clear answer to that.
But Steven Snyder is really against the thermal shrinkage.
Yeah, I mean, to be honest, I'm not using it anymore.
Okay.
I'm not using it anymore because I can do. This was done in the late 90s, the mid late 90s. We didn't have by then still we didn't have good instruments to do arthroscopic surgery. We had very, very crude instruments. Now we can do everything. We can do plications easily. We can do everything much easier. So I think that's why it came out of fashion. And the fact that people really abused it with high energy and it burned capsules out. So it came out of fashion. And of course, I have to remember again what we just mentioned, doing a posterior plication if necessary in these patients, if you need to do an anterior stabilization and posterior plication. Thank you very much.
Just one question. I would just ask you, about the plications. What do you think of the multiplications of that is so-called the 360 applications for these multi-direction cases?
Well, first of all, if you do a good release around, that's the idea of the purse string. If you do a good release around and you do the purse string technique, you actually tighten the whole capsule. So usually you don't need to have to do much of posterior plication, but there are the cases where either it was a long-standing and being for a long time the patient dislocated posteriorly, and he's got really a big redundant capsule at the back. I would add a posterior plication at the back as well. But otherwise,
repair. A posterior plication with a posterior banker repair.
Yes.
Okay.
Yeah.
Can I just ask on that? Now, let me just clarify this. If you've got somebody, you've made a decision that you're going to operate on somebody with multidirectional laxity, and your MR-arthrogram showed a large recess, are you going to create a Bankart lesion, or are you going to placate the capsule inside you to the existing labrum with using anchors or whatever?
I would probably create a Bankart lesion in order to do a shift from inferior, from south to north, to tighten the whole big recess. And not only the recess, because I will create the Bankart actually go even posteriorly to make the shift from posterior to anterior, to tighten the whole thing.
So you don't believe in just pulling up the inferior capsule and tying it to mid-labrum, tightening the capsule and to do it front and back? Because
it's a good question, but the thing is, what you have to do is you have to abrade the capsule to make it more reactive to heal. Because otherwise, you put the sutures will go and nothing will heal there. So and the capsule is usually so thin in these cases that I prefer to have a good tissue to attach to the bone.
And some blood, and some bleeding also.
And some reaction. Yeah.
Okay, because my philosophical objection against that is that the best attachment of the labrum to the glenoid is provided by nature. And when you do your purse string, I'm not talking the post-traumatic one, I'm talking these ones.
Yeah.
You're still relying on your labrum healing to the glenoid. So you had a well-healed, well-fixed glenoid, labrum which you have detached, and now you want to heal it again. Why not just tighten and scar up the capsule, and that's application front and back?
Well, that's the question. How can you scar the capsule? Because the capsule is there not to scar. I mean, that's normally the capsule is there to be a gliding surface. So you need to create some abrasion of the capsule to create some reactivity there. Again, I'm not sure that I'm right, but to create this reaction of the capsule, you may risk by tearing the whole capsule or destroying the whole capsule. And I feel better to have a good hold, good tissue that I can really pull and fix.
That was my point, that you want a good hold and good tissue to fix. But inherently, in such cases, the capsule itself is of so poor quality that you might just rip everything and have nothing out there. Is that?
Well, that's why you create the Bankart and take the good edge of capsule with a good bite of the capsule. You decide how much bite you want to take, and then you have a better quality tissue to pull up, and this will heal because you created reaction there.
A better quality and a bigger amount.
A bigger amount of shift, yeah.
If you can just step back a bit, for those who you do not operate, how does this biofeedback, how do you do it, or how does your rehab department do it? Just to throw some light so that...
Well, it should be one-to-one physio with a physiotherapist. These are difficult cases. They need to know the patients, and I tell them it's not a quick fix. It's not that they've seen the physio once, twice, and that's it. It's going to take at least 6 months of really hard work and really good compliance from them, because otherwise it will not work. The people who are, some of these guys are computer guys, IT guys and all that. I tell them, you know what we need to do to you? It's what you need to do to your computer when it stops working. Completely, reformat the hard drive. That's what we need to do to your hard drive. And it's like that, because they develop this pattern of movement. They know how to do it, and they don't know any other way. So there's a good Jo Gibson from Liverpool. She's one of the leaders in this, and she had a very good presentation in BESS a few years ago and she really showed a guy that came with muscle patterning, and within one session she showed him that he can control it. Now, it wasn't the end of story, but this was just to convince him that that's the way forward.
And did he defeat, but he did physio?
Yeah.
And good?
Yeah, I mean, we have good results with that, but it takes long time.
And discipline.
And discipline, yeah.
How do you manage the internal impingement?
Well, the posterior superior impingers. Well, that's...
Come out anteriorly and impinge posteriorly.
Well, they're not unstable, the majority. I mean, there are two groups, two schools, I would say. The school of Job that said that they are unstable and because of that they impinge. And I think there is a normal impingement posterior superiorly that's what Gilles Valls said. And you can see that normally, in a normal shoulder, we have posterior superior impingement, but we don't do this movement enough repetitive times to develop it. And throwers or things like that, or
No, I'm seeing those quite a lot recently actually, because patients are a bit more laxer than normal.
Yeah.
And if you get an MR arthrogram, the labrum is not completely ripped off. There's a slight abrasion and just slight.
Posterior superiorly.
No, the anterior labrum is gone.
Mhm.
Posterior superiorly, there is edema on the
Yeah.
humerus, and the cup is intact. So very difficult group to manage. How do you approach those?
If they have any labral lesion in the front, I would probably fix them, stabilize them. Yeah.
The other thing is, what is their internal rotation? Are these the ones with a GERD deformity?
Yeah.
Do you try and restore their internal rotation and see what's happening to their external rotation? The other thing is, what is their sport? If they're in a sport which puts their arm consistently in this position, a javelin thrower or an overhead tennis player, they have got that problem.
No, majority of the guys I've seen are occasional cricket players.
Yeah.
They throw a ball and they say, or occasional badminton players. They are recreational sportsmen. They are not professional.
I would agree with Offer. I think these guys have got an anterior instability, and if you see a little lesion where you can put your probe between the labrum and the glenoid, for me that is a labrum injury, and I would fix it.
But is that anterior instability a cause or the effect?
Effect. That's what I was saying.
Do you want them to go
He
back
doesn't-
playing or not?
well,
Yeah, I send them back playing. I
Yeah.
had a very similar one, which was a schoolboy who's a Scottish javelin thrower, and his problem was lack of strength, because he